Hi, I'm Jack Cush, executive editor of RheumNow.com, and this is the RheumNow Week in Review. This week, we're going to talk about a lot of the new things, but first I want to tell you about RheumNow blogs. We've added a new feature for those of you who listen to the podcast, where you consume your podcast, whether it's on iTunes or SoundCloud or Stitcher. You can actually look for a new podcast from RheumNow called RheumNow Blogs. These blogs tend to be blogs that I've written in the past that now you can have in audio format. Look for those. I think you'll enjoy them. This week, we're going to talk about a few new things. Is gabapentin your drug that you should be worried most about? Is vitamin D your most useless drug? Is your approach to joint taps correct? I'm going to give you either a straightforward or a sideways answer to that one. And how much does a drug study actually cost? At the top of the news, we have medical marijuana. As you know, I think it's sort of approved or in some phase of approval in almost 30 or 37 states in the United States. It is approved for commercial use in Canada and the UK. And obviously its use is growing. A new report comes from the state of Illinois, which has been approved now for almost 2 years. And they show in their last fiscal year, marijuana use is up to 83% with a total of 46,000 consumers in the state overall. That amounts to about $12 million in sales per month. The most common use is in PTSD, which actually has surpassed fibromyalgia, PTSD in 4,000 people, fibromyalgia in 3,400 people, and cancer-related use in 2,500 people. Medical marijuana is here, and it's big business. Interesting reports have surfaced in a few new spots, I think sort of ignited by some presentations at the annual pain meeting recently, but gabapentin is really under the microscope as a potential drug of abuse. It is the 10th most commonly prescribed drug in the United States, and it's estimated that about 1 in 5 opioid abusers, which we know there are many, and that's problematic for society, costly for society, that 1 in 5 of those are actually abusing gabapentin. And that's not just in the United States, but also throughout Europe. Now, we know that a lot of the problem with gabapentin is that there's a lot of off-label use. It is an anti-seizure medicine, but it's being used in rheumatology for pain management and for fibromyalgia management. But again, it is widely used, and therefore it expands its potential for wide abuse. And these numbers are not trivial. If you look at overdose deaths in certain states, gabapentin is the cause of overdose death, or one of the causes. In Tennessee, 4%, not so much. But in other states, North Carolina, 20%, Kentucky, 41%. In many states, it's gone to become a Schedule 5 drug. I recently went to find a prescription for Lyrica and gabapentin in the state of New York, only to find out that it was a Schedule 5 drug. And so this is a bit of a problem and needs to be sort of reassessed by rheumatologists and how they use it. Interesting information comes from ILAR and Printo, who are looking to develop a new classification criteria for juvenile idiopathic arthritis. What, another one you might say? Well, again, they're doing it. Then the proposal that's on the table for a Delphi-like procedure is that they're suggesting there may be 4 groups. And that JIA can be divided up into 1, systemic JIA, 2, seropositive JIA, rheumatoid factor positive JIA, number 3, enthesitis spondylitis related JIA, and lastly, early onset ANA positive JIA. If you look at the history of JIA and its classification, it's gone through a lot of changes in recent years. Many of you grew up with 3 types of JIA, oligoarticular, polyarticular, and systemic. Obviously, this has been tricked up quite a bit. The question is this really useful? I think, obviously, we should be guided here by differing mechanism of action, noting that a different group may have actually a different outcome, especially if there is an MOA associated with that, because with those two, you can develop maybe more rational and more successful therapies. Again, my main gripe in JIA research is that even that there are many groups, you find a study done and they've included all the patients, oligo, polys, ERAs, etc. And that obviously makes no sense going forward. So hopefully this will be in advance. We'll wait and see. A large analysis of Medicare claims data looked at something I didn't know there was an association, but it's often stated that PPIs may give a higher risk of osteoporosis by impairing calcium absorption. And again, the data for that is somewhat sketchy and weak from what I've seen. Again, a Medicare claims analysis of almost 5,000 patients who were on hemodialysis with end-stage renal disease and compared them to 45,000 controls and showed that both a PPI and H2 blocker use was associated with about a 25% increase in the risk of hip fracture. So maybe there is something to this. But again, that's already a group that's already at high risk, meaning ESRD patients on hemodialysis for osteoporosis and obviously hip fracture. Will this be worsened by PPI use? Obviously, you need to be more judicious in your use of PPIs in these people. We put up a Twitter poll this week. I don't know if you do Twitter or look at Twitter polls. I like them because you get sort of on-the-spot answers. And this stems from a discussion had in our clinic. But although we don't see data on this, I do see some people, and even in my own practice, the practice of combining apremilast, also known as a Tesla, with a biologic, either with a TNF inhibitor or an IL-17 inhibitor. So I asked on Twitter, do you combine apremilast with a biologic in your difficult psoriatic arthritis patients? We had 81 respondents from rheumatologists. Hopefully they're truthful in saying they're rheumatologists. And the answers were as followed. About a third, or 36%, said no, never. About 26% said they can't get approval to even consider it. And then there was 26% who said, yes, I've done it and I've seen benefit. And another 12% who said, yes, I've done it, but I've seen no benefit. I do believe this is not an uncommon practice, meaning it's more than we probably realize. I'm just not clear whether or not there actually is any benefit. I think these kind of results may spurn the company to actually do a study in this area. As best I know, there is no study combining two very expensive drugs, a biologic and apremilast, in patients who have problematic disease. I found a nice study that looked at the comparison of approach when doing arthrocentesis of the knee. It's a small study of 55 consecutive knee, 20 of whom had the extended knee, and 35 had one was the anterior approach, the other one was the lateral approach. So it's extended knee, meaning an anterior approach with a flex knee. Extended knee with a lateral approach and a flex knee with an anterior approach is what's being compared here. 25 in one group, 35 in another. They found twofold better results with the extended knee approach, meaning a lateral or medial approach. They had better yield in the amount of synovial fluid and more successful fluid aspirations, meaning they got more than 2 cc's of fluid. They did show, however, that if you do mechanical compression of fluid from the suprapatellar pouch, it didn't seem to matter whether you used a flex knee approach or an extended knee approach. So that's something for you who consider yourself expert at knee aspiration. An interesting study looked at the risk of developing extraspinal disease in patients who have axial spondyloarthritis. So this is a study from Belgium, 1,250 patients, called the ASPECT trial. And then they retrospectively looked at what happened to their axial SPA patients. And they found that IBD and acute anterior uveitis, but not psoriasis, were consequences of axial spondyloarthritis, especially related to disease duration and the amount of inflammation. So psoriasis, not so much, but the risk of IBD and maybe uveitis is related to disease duration and inflammation. So there's a nice report also in BMJ about tocilizumab and Still's disease. This comes from Tom Taguchi's group. It's a small study, but it's a placebo-controlled trial where patients are getting 8 milligrams per kilogram of tocilizumab. And their primary endpoint in the study, a phase 3 trial, was the reduction in joint scores, an ACR 50 at week 4. And they were obviously looking for a big response and a big fast response. What they did see was the ACR responses were 61% on tocilizumab and 31% on placebo. And that, although that was better in a small study, it was not yet significant. They did show significant results for the reduction in steroid dose by the tocilizumab group compared to placebo. And they did show highly significant ACR 20, 50, and 70 results at week 52, meaning they had ACR 20 of 85%, ACR 50, 85%, ACR 70 of 61%. What does this mean? Well, one, it's a small study. And two, it's really hard to do large studies in Still's disease. So you have to take it for what it is. Assuming the diagnosis is right, I really want to know more about fever and systemic manifestations than I do want to know more about the joint manifestations. But if this only looks at joint manifestations, it tells you that IL-6 inhibition is good, but not perfect, because you're not getting 100% ACR 20, 50, 70s at 1 year, and your ACR 50 is only about 2/3 responsive very early on. So it's good for joints, and we certainly know it's good for systemic features like fever, serositis, high white count, high sed rate, CRP, ferritin, et cetera. So this is good data, but again, we still need to probably better stratify our patients and have a more rational approach to treating people with Still's disease. JAMA has a very interesting review on the cost of clinical trials. I said for years and quoted multiple sources saying it takes at least $2 million in 10 years, and that number keeps going up and up and up. As far as how much a study costs, actually, I said $2 billion in 10 years to develop a drug. Turns out that when they looked at 138 pivotal randomized controlled trials done for 59 FDA-approved drugs between 2015 and 2016, the median cost per clinical trial was $19 million. Very cheap if you're doing a few patients with an orphan drug trial. It could be maybe $1 million or $5 million, but very expensive for non-inferiority design. So the takeaway from this is that actually the trials are very expensive, that non-inferiority trials are really expensive. And one of the comments in social media was that the real cost of these trials actually is in the post-approval commitments that are required by the FDA. Those also are incredibly expensive. So the number of probably 10 years and $2 billion or more to develop a trial is probably closer to truth than you might imagine. A very interesting study appeared today, October 4th, and today's October 5th, but yesterday in Lancet, showing that vitamin D, it really doesn't affect bone health. And that included, it was a meta-analysis of 81 trials and over 53,000 patients. Most of the trials were more than a year, and greater than 2/3 of the patients were elderly women over the age of 65. Basically, they found that vitamin D supplementation and vitamin D dosing had no effect on fracture risk, relative risk of 1.0, hip fracture risk, a relative risk of 1.1, or change in DEXA scores, regardless of whether that was followed over 1 year or 5 years. So vitamin D, given just as a routine in different situations, especially postmenopausal women, in and of itself does not seem to affect the outcomes. And the authors say it is indicated in certain situations, in high-risk situations, and there may be benefits to it. But overall, these results are disappointing and suggest that there may not be any rationale behind routine use of vitamin D supplementation. Two more studies. Zoledronic acid, a drug that was approved in 2007 for osteoporosis in the United States, actually was studied in elderly women with osteopenia. So there's a large number of women enrolled in the study that had a mean T-score about -1.6, 10-year hip fracture risk of 2.3%. After being followed for 6 years, the fracture rate, the fragility fracture rate, and the hip fracture rate was really no lower. Overall, the fracture rate was about it was lower. It was 37% lower, and that was significant, suggesting that the number needed to prevent a fracture in an osteopenic postmenopausal woman was 15. The NNT was 15. In the study, there was no reports of atypical femoral fractures, osteonecrosis of the jaw. They did show that zoledronic acid was associated with overall lower rates of cancer, myocardial infarction, and overall death rates, suggesting that this might be a reasonable approach. So again, where would you treat patients with osteopenia? Again, this might be something to consider. Lastly, predictive factors for uveitis and JIA. Most of us think we know that, but this is an interesting study that looked at, I think, almost 1,000 patients, 900 patients. And the predictors for development of uveitis, if you have JIA, was younger age at onset and ANA positivity, and those were highly significant. But there were other factors that were worth mentioning, including high baseline sed rate, high baseline S100 levels. That's another inflammatory marker, and measures of disease activity throughout the course of disease, all predictive of uveitis. What helped to prevent uveitis events, you might say? Number one, methotrexate. Number two, etanercept. And number three, adalimumab, with anywhere from a 90 to 82% reduced risk of developing uveitis when using methotrexate, etanercept, or adalimumab. Well, that's it for this week. I want you, though, to know that we're going to have a big activity at ACR this year. Make sure you come by our booth and say hello. Note that we're going to have a lot of new features on our featured website, which will go live at the meeting, which is acr18.rheumnow.com. You'll see a few new things, including audio commentaries on the posted pieces that we have. You'll see some live, YouTube live transmission of panel discussions that we're going to have on rheumatoid arthritis, ankylosing spondylitis, gout, and psoriatic arthritis. We're going to have very specific coverage of a number of areas, including those in vasculitis that you'll see featured on the website. Be sure to tune in while the meeting's going on and after the meeting. I think you'll enjoy the content. That's it for this week at RheumNow.com. We'll see you next week.